Hello everyone, this is Dr. Meenakshi Gupta. So today is the third video on the topic anti-malarial drug. If you haven't seen the previous two video, I will be giving link in the description box. You can go and watch the previous two videos. So in today's video, what I will be taking the slow acting erythrocytic sysonticide. So whatever is left, I will be taking it today. This drug, Proguanil, then Sulfonamide, Pyrimethamine, Primaquine, Tafenoquine, Doxycycline, and Clindamycin. So this group, five group of the drug, they are left. All rest of the drug I have covered in my previous video. So coming to the first one, this 8 aminoquinolones. Under this category, we have two drugs, Primaquine and Tafenoquine. So Primaquine. Primaquine, as in a previous two video I have told, it is going to act at three places: at pre-erythrocytic, then exoerythrocytic, then gametocidal. Okay, so it is a tissue sysonticide as well as it is a gametocidal action. So for the pre-erythrocytic, we can use it for the casual prophylaxis. For the exoerythrocytic, we can use it for the radical cure, and it is going to cut down the transmission from the host cell to the mosquito, so that further there will be no transmission. But it is a no, what is here the main thing is no erythrocytic sysonticidal action. So that means if the person's with the malaria having the symptoms, it is not giving any relief. So this drug, it is mainly used for radical cure and for the gametocidal action. We give it by oral route. Half-life is 6 to 8 hours, and it is not a cumulative drug. This is important. Now where we are going to use, this is mainly used for the radical cure. It has got two action. One is it is going to act on exoerythrocytic and gametocidal. So it is going to provide two radical cure as well as gametocidal. Now in Plasmodium vivax, we need a radical cure. So in Plasmodium vivax, we are going to give the patient chloroquine plus we are giving Primaquine for how many days? 15 milligram for 14 days. So this is going to prevent for 14 days. So this is going to take care of both relapses, so no relapses, plus it is also going to have a gametocidal action. Rather, chloroquine itself has a gametocidal action in case of Plasmodium vivax. Now there is no exoerythrocytic phase in the Plasmodium falciparum. Do we need to give Primaquine in Plasmodium falciparum? Yes, we need to give the Primaquine in Plasmodium falciparum, but we will be giving a single dose of 45 milligram, and this is going to exert the gametocidal action. Okay, so these are the uses of Primaquine. Now what are the adverse effects? Adverse, it's a well tolerated, few mild GIT side effect, and the most important side effect with the Primaquine, that is hemolysis, especially in G6PD deficient individual. And G6PD deficiency, it is very low among the Indians, seen in the Mediterranean person and in the black races. And for this, there is a spot test. And if it is a positive, that means person is G6PD deficient, then this drug should not be given. And how you'll come to know? There's a passage of dark color urine, that is the indication of the hemolysis. And if this thing happens, immediately stop this drug. And the Primaquine, it is important is another is Primaquine is contraindicated during pregnancy because the fetus is G6PD deficient. So this is about the Primaquine. Another drug in the same category, that is the Tafenoquine. Tafenoquine, what is the good thing about this? Its half-life is 14 to 19 days. So we have to give Primaquine in case of Plasmodium vivax for 14 days. And this drug, just we have to give a single dose. Instead of 14 days, we have to give, how? We have to give a single dose. And it has undergone the phase 3 clinical trial 800 milligram over 1 to 3 days along with chloroquine for the relapse prevention, and it has achieved 100% relapse prevention. So received the approval from US FDA in July 2018. So this is about 8-aminoquinolone. Now next I will be taking these group of drug together, this and especially this one, sulfadoxime, pyrimethamine. So if you remember cotrimoxazole, okay, how that is a combination of cotrimoxazole, sulfonamide and trimethoprim. Okay. So how the sulfonamide, that is the mechanism of action of the sulfonamide. So sulfonamide, whether it is a short acting, intermediate acting or a long acting, the mechanism of action, it is same. So its structural resemblance with the para-amino benzoic acid. So what will happen, because human we get it from the dietary source of the folic acid, but the microorganism, they make their own folic acid. So what will happen? This sulfonamide, it is going to compete with the para-amino benzoic acid, and instead of para-amino benzoic acid, what will microorganism, they take up the sulfonamide. So further the folic acid synthesis, it hampers. So folic acid synthesis and utilization, the first step where the para-amino benzoic acid, that is converted into dihydrofolic acid with the help of enzyme folate synthetase. This is inhibited by sulfonamide. Now from the dihydrofolic acid synthesis, there is a synthesis of the active form of the active form of folic acid, that is a tetrahydrofolic acid, which is inhibited by the trimethoprim, and this step, it is with the help of dihydrofolate reductase. Now if we are going to give this, here the sulfonamide which we are using as an antimalarial is sulfadoxine, sulfamethopyrazine and dapsone, and diaminopyrimidine, that is a pyrimethamine. Now if we are going to give a combination of this sulfonamide and pyrimethamine, then what will happen? They are going to block this in sequence. So there is a sequential block of this folic acid synthesis. The only thing is there are three drugs, trimethoprim, number one is this, other one is a pyrimethamine, and then one more, it is a methotrexate. All the three drugs, they act by inhibiting this enzyme, dihydrofolate reductase. The only difference is trimethoprim, it has got more sensitivity for the bacterial dihydrofolate reductase. Pyrimethamine, it has got more sensitivity for the plasmodial dihydrofolic acid reductase, and methotrexate, it has got more sensitivity for the mammalian dihydrofolic acid folate reductase. So trimethoprim, it is used as an antibacterial. This one is used as an antimalarial because it is acting against the plasmodium, antimalarial, and this is used as an anti-cancer. Now coming to this one, how this step, what are all the drugs, other drug which are going to inhibit this? Another drug is Proguanil. This also inhibit this. So how it is going to inhibit? It is a prodrug, undergoes cyclization within the body and form a triazine derivative which is going to inhibit the plasmodium dihydrofolic acid reductase enzyme. So it is a slow acting. Now talking about all of them, they are the slow acting erythrocytic schizonticides. So it inhibits there is a no gametocidal action, but once you give this drug, then what will happen? The further development of the gametes, they are failed in the mosquito. And how we are going to give? We give it by oral route. Already told, it is a prodrug converted into the cyclic form, that is cycloguanil, and half-life is 16 to 20. And it is mainly used in combination with atovoquinone. So already I have told in my previous video. So next is pyrimethamine. Pyrimethamine, it is a direct. ये डायरेक्ट inhibit करती, there is no conversion, no, it does not undergo any cyclization. Other thing, they are same. So it is also erythrocytic schizonticides, slow acting. जैसे अभी Primaquine पढ़ा, Tafenoquine पढ़ा, they are not erythrocytic schizonticides. They are for the radical cure. They had gametocidal action. They act on the pre-erythrocytic phase. But इसमें क्या है? They are only acting on the erythrocytic phase. No action on pre-erythrocytic, no radical cure. ठीक है? Then it is given by oral route and concentrated in liver, spleen, kidney, lungs, metabolized in the liver, excreted in the urine with a half-life of 4 days, and prophylactic concentration remains for 14 days. Now, pyrimethamine, it may cause rarely the folate deficiency or megaloblastic anemia, and granulocytopenia may occur with the high dose. And usually we give it along with the sulfonamide or a dapsone. इसको बेटा कभी अकेले नहीं देते. We always give in a combination. Now sulfonamide and pyrimethamine combination, because they are going to block the step in sequence. So this is a synergistic. Both are bacteriostatic, or both they are. Once we are going to give this together, they form a synergistic combination because of the sequential block. What are combinations? Sulfadoxine, pyrimethamine, sulfa-methopyrazine, pyrimethamine, and dapsone. So these are the combination of sulfonamide and pyrimethamine. And now where we are going to use the drug of choice for the toxoplasmosis. Then in case of malaria, for the treatment, for the plasmodium vivax, it's a big no-no. We are not going to use it for the plasmodium vivax, because plasmodium vivax, they do not show any efficacy for this, whereas we are using it for plasmodium falciparum, and there we are going to give a combination of this sulfadoxine pyrimethamine with the artesunate. This already I have told in my previous video. Then prophylactically it is intermittent preventive treatment. IPTP is intermittent preventive treatment during the pregnancy in the 2nd and 3rd trimester. Gap should not be more than 1 month, and there is a single dose of sulfadoxine 1500 milligram plus pyrimethamine 75 milligram. This is used prophylactically, and side effect mainly with the sulfonamide component like exfoliative, dermatitis. Then there is a Stevens-Johnson syndrome. So these are the important adverse effect with the sulfadoxine pyrimethamine combination. So another bacteriostatic drug, that is doxycycline. So this is also a slow-acting antibiotic and with the erythrocytocidal action, and mainly it is used against the multi-drug resistant Plasmodium falciparum. So it makes a synergistic combination with the quinine, artesunate, दोनों के साथ हम इसको देते हैं. So where the Plasmodium falciparum, if it is showing the resistance with the chloroquine, mefloquine, and sulfadoxine pyrimethamine. Suppose if it is a even it is used in the Plasmodium vivax also. In the Plasmodium vivax, we give it as combination with the quinine and doxycycline if it shows resistance to the chloroquine. So where we are going to give from the vivax, quinine and doxycycline, and in Thailand mefloquine, chloroquine, any, then we are giving it with the artesunate. Prophylactically, already I have told prophylactic, suppressive prophylaxis, if it is a less than 6 weeks for the short term, we are going to use doxycycline 100 milligram OD. We have to start 2 days, and once the person come back again continue for the 4 weeks. Then another bacteriostatic antibiotic, Clindamycin. This also used for the wherever the Plasmodium, it shows the resistance, and it is used where we cannot use the doxycycline, especially in children and in pregnant women. So here, along with quinine, instead of giving the patient doxycycline, we are going to give the clindamycin. This is 600 milligram 3 times a day for 7 days. Clindamycin is also 12 hourly. We give 600 milligram 12 hourly for 7 days. So this is all about the slow acting erythrocytic scisonticide. So I have covered all the individual anti-malarial drug, all the important point I have covered. Now, how to treat it according to the guidelines. So first we had a national malarial control program. ठीक है, सबसे पहले तो ये है its control program. Then we have a national malarial eradication program. This was renamed as National Anti-Malarial Program and further renamed as National Vector-Borne Disease Control Program. Now what the guidelines is? So mainly we have to treat two species, Plasmodium vivax and Plasmodium falciparum. Okay? So coming to the first one, Plasmodium vivax. Now what to give for the Plasmodium vivax? So we will be giving chloroquine, so already I have told 600 milligram followed by 300 milligram after 8 hours. आपको 4 टैबलेट देनी है followed by, write it again. So we are giving chloroquine 600 milligram followed by 300 milligram after 8 hours. This is the day 1. Then day 2, again chloroquine 300 milligram. Day 3, chloroquine 300 milligram. So this is going to take care of the erythrocytic phase, And along with this, we are going to give the Primaquine, 15 milligram per day for 14 days after the G6PD test. And this treatment, it is for everyone. This is for the all the males, patient, non-pregnant females, then pregnant females and children. So if vivax, it shows the sensitivity, or according to the National Vector-Borne Disease Control Program, this is the treatment. Now for the Plasmodium falciparum, what we are going to do for the Plasmodium falciparum according to the National Vector-Borne Disease Control Program. So this is further of uncomplicated, and we have a complicated, or we can say the cerebral malaria, severe malaria. Okay. So with the uncomplicated, in our country, irrespective of the chloroquine status, we are going to put the patient on artemisinin combination therapy. So we are going to give artemisinin combination therapy. And which combination we are going to prefer? We are going to prefer artesunate with sulfadoxine pyrimethamine combination in all except in northeastern region, where we give artemether with the lumefantrine combination. This is the northeastern region, and this we give by oral route. And see, artemisinin combination, this is we cannot give during pregnancy. So in uncomplicated, this is ये किस किस में हम दे सकते हैं? This we can give in male patient, non-pregnant female patient and children. Whereas in pregnant female patient, what we can give in pregnant female patient, we have to give quinine 600 milligram 3 times a day for 7 days. With the, we cannot give the doxycycline also, clindamycin 600 milligram 12 hourly for 7 days. Now for the complicated or a cerebral malaria. Earlier we used to give a quinine, IV quinine we used to give, but now we prefer artesunate. See, it is a ACT combination. In here we are going to put the patient on artesunate IV, not the quinine. Quinine is now not a drug of choice. It is a second line drug of choice if the person cannot tolerate the artesunate. So artesunate IV 2.4 mg per kg over a period of 4 hours you have to give. And this IV therapy, it has to be given for minimum 24 hours. And once the patient is conscious, after the 24 hour, whenever the patient gains the conscious, then switch over to oral artemisinin combination therapy. Okay. So this for the pregnant female, it is for the only for the first trimester. ठीक है, यहाँ पे नॉन प्रेग्नेंट फीमेल प्लस आई वांट टू ऐड pregnant female second and third trimester, and this one is for everyone. irrespective of the pregnancy, whether it is a first trimester, whether it is a second trimester or a third trimester, we have to give this artesunate by IV route. That's all about the anti-malarial drug. If you have any query regarding this video, so you can ask your query in the comment section. Thank you for watching my video.